So this is once again an overview of school health services presented by myself. And our location is the ground floor Pontiana building at the Ministry of Health and Wellness, meeting in Augusta Street, located in Nassau, Bahamas. Here you'd see our staff. We are a wonderful group of 27 registered nurses. We have one clerk and myself, the supervisor. Of course, that's not the whole 27, but that's the majority of them. So the objectives of this teaching, one, state the mission and goals of school health services, outline the job description of a school nurse, list government schools under Providence, discuss the at-risk student, state the reporting obligations of the school nurse, list referral agencies, discuss the importance of health education, discuss training and annual workshops, examine the impact of coronavirus on school health, discuss the isolation protocol on the school campus. We'll also discuss challenges and rewards, and then also finally state the future plan for school health services. So our mission statement says to provide comprehensive health services to school-age children in the public sector to ensure that they achieve and maintain the highest level of health care in order to receive the maximum benefit of a good education. And so some of our goals include establishing a good working relationship with our stakeholders being our parents, the wider community, anybody that would want to take part in, the building of our children and community in their lives. Decrease absenteeism from school due to ill health. Identify and reduce the factors that promote ill health by carrying out physical and psychosocial examinations. Treat minor ailments and then refer all abnormalities immediately. Identify and follow up our at-risk students, and we'll talk a bit more about our at-risk students as we go along. Promote healthy lifestyles through health education, which is a big one. School health nurses must love to educate students and faculty and staff. Keep record of all examinations and treatments that are given to each student. Collect and analyze that data in order to evaluate the overall standard of care. Strengthen the knowledge and skill set of the school nurse through continued trainings, for example, emergency care, her BLS, her ACLS, visual acuity. And so we believe that education for the school nurse has to be consistent and ongoing. So then we'd ask, where does a school nurse work? Obviously, she works in the school setting. So you may find her in other areas of healthcare, but a school health nurse works in the school system primarily. In New Providence, we have 8 senior schools, Anatole Rogers, C.I. Gibson, C.C. Sweeting, and the list goes on there. And then we have 7 junior schools, A.F. Adley, C.H. Reeves, C.W. Davis, and then you see the list goes on. But we have 24 government primary schools, a whole lot of primary schools compared to our senior and junior schools. And there you see the names of those schools. Most of them are named after very important persons who would have taken part in education. And the list goes on: Sybil Strawn, T.G. Glover, Thelma Gibson, Uriah McPhee, Woodcock, Yellow Elder. And then we have 7 special needs or alternative schools: Center for the Deaf, School for the Blind, Marjorie Davis Institute, Penn Pratt, Stapleton School, Transitional Alternative Program for Students we refer to as TAPS, and then Program Shaw. Many of these schools are rehabilitative schools or behavioral schools that cater to behavioral issues. And then if we were to look at our population by grouping, we'd see that our junior school, 6,061 students as of 2021. Senior school, 7,126. And our primary schools, 12,662. Alternative schools, 307. And so you can see that our primary schools double the population of our senior and junior schools. So what is the task of the school nurse? What is it that she really does? So her job description includes, of course, building a good working relationship with school staff. You have to have good communication skills. You have to be able to get along with the persons that you work with. And so that's one of her jobs. That's a job description that she has to fulfill. Also maintain a communication system between Ministry of Health and Wellness and her assigned school. So she's the liaison, she's the bridge between what's happening at her school and Ministry of Health and Wellness. Her hours of work are 8 to 4 with 1 hour lunch break. And in the absence of school, she is deployed or sent to other areas. She does not get a summer break like the students. She is sent to other areas to cover other vital need that the that the health system may have. So she doesn't go on vacation at that particular time. She's sent in another area to work until school reopens. Currently, school is closed, and so 27 of our school nurses are deployed to other areas until school opens on the 29th of August. She must also maintain an address register. We'll talk about that as we go along. And then, of course, like I mentioned before, she must love teaching. So she makes health education presentations to PTAs, any general assembly, anybody a health talk, a school nurse. So she most definitely engages in health education all the time. Attend continuing education sessions and workshops at Department of Public Health and Wellness. And so, like I mentioned before, it is very important that she stays up to date with her BLS, ACLS, eye testing and all that stuff so that she could be an asset in the school community. And then she's to collect and analyze data for monthly reports because then they're working. And so, of course, you need to know what's happening on the school campus. She reports back and say, this is the finding, this is what's happening. And of course, she reports all emergencies to school health services as well as to the school administration. And so, of course, we send her out there totally and fully equipped as much as we can with her stationary needs, sanitation needs, of course, antibacterial hand wash, hand sanitizers, even toilet tissue, because then now we're responsible for the nurse while she's out there in the school environment because she functions kind of like a manager on her own, more or less. And so we ensure that she's equipped with everything that she needs. This supply is restocked on a monthly or weekly basis, depending on the need. So of course, you see safety supplies, isolation gowns, N95, surgical masks, nurse caps, shoe covers, face shields, because of course we're still in COVID. And then her nursing care equipment, glucometers, thermometer scale, oxygen tank as needed, medication, BP machine, and stethoscope. One note to medication. The medication that the school nurse prescribes or administers is basically over-the-counter medication. It's nothing prescribed by the physician. It's generally anything that a parent can go into a store and purchase. The paracetamol, the Motrin, those things. With an exception of a Ventolin inhaler, nurses do have Ventolin inhalers that they may, with a doctor's prescription, give to our asthmatic students. And so speaking of asthma, the at-risk students is any student with any adverse physical, mental, and or social condition that prevents the normal progress of cognitive development. And that means any pre-existing medical conditions, whether it's asthma, diabetes, hypertension, any cardiac issues, any physical limitation, anything that could, stop a student from gaining the best from the educational system. And that can come in any form of your medical conditions. And so how do we identify and manage our at-risk students? So of course, early identification and treatment and management of the at-risk student enables them to make have a good term, and make the best of their education. So if we know who they are offhand, then we can intervene and ensure that they get the best from the educational system. Now, these students entering grades 1, 7, and 10 undergo annual screenings, and that's to detect any deformities or deficits that they may have. That's how we identify them. Their school medical would say what's happening with them, and also by a doctor's diagnosis. Now, bear in mind, a nurse may be transferred to a school and she sees a student in grade 8, doesn't have a school medical in front of her, but we have something called the hospital liaison list. That list comes from the hospital liaison department. And what it is, it allows us to pinpoint those students who would have been seen in accident emergency or been hospitalized. So you can look at that listing that the hospital liaison officer provides, and then you're able to pick out students that were seen, because you may have never have known that Desdemona Henfield has asthma, but she may be on the list that she was seen at accident emergency. So this listing is grouped by name, age, and school. So all of our school nurses, when they report in the morning, they look at the listing that is provided to see if they pick up any new students. And then it is their responsibility, their job, to go and find these students. You know, whether by grade or there's a telephone number attached and they can call and see if the student is still in hospital, as the student changed school, so that we can, you know, introduce ourselves to these students and see how we best can help them. And so these students are managed by being seen in various clinics for follow-up care, whether it's specialty clinics, medical clinics, and also they're seen by the school nurse at intervals. So the school nurse puts together a listing of all of her at-risk students, and that's what we call or refer to as the at-risk register. So each at-risk student, no matter what medical condition that they may have or psychological, any pre-existing medical or psychological conditions, they are grouped on a list, and then the nurse formulates a plan as to who she will see when. So most often it's done on a monthly basis. So she may see an asthmatic at least once a month, depending on how many she has, and then she can see them however she wants to see them, whether it's on a lunch break or during chapel in the morning. She can decide how she's going to see them to ensure that she sees all of her at-risk students, just to touch base, to say, do you have your medication? Did you keep your appointment with the physician? What did the physician say? You know, that sort of stuff. So, and I feel that if you do that early, there are less chances of a student having difficulty on the school campus if you ensure that they have their checkups on a regular basis. And so a school health nurse sees minor ailments. So students with minor ailments such as your cough, cold, menstrual cramps, minor abrasions and injuries, etc., are seen and treated by the resident nurse, or depending on the situation, referred immediately for further evaluation for more serious conditions. It may seem small at the beginning, but of course, a nurse is trained to assess if this is more than it actually appears to be at this point in time. So all visits to the school health nurse are documented just to monitor illness category, incidences, and frequency. We want to know what it is that we're seeing, how often are we seeing it, you know, and among which group are we seeing these things happen. All notifiable diseases and trends are, of course, reported and followed up by the surveillance unit. We talked about reporting. Now, the nurse is obligated to report every single thing that may be of importance. So a monthly report is formulated for each school by the school nurse. An annual report is provided by the nursing supervisor, school health supervisor, and all nurses are obligated to report all suspected cases of abuse or any situation they may feel that a child is in danger of being in. And of course, all adverse cases and emergencies are reported immediately to the supervisor of school health services, and she reports to Ministry of Health and Wellness. And of course, the school must be notified of anything that's happening that may pose a threat to the wider community of the school. Now, minor ailments monthly reports may take the form something like this. So the nurse graphs her report based on what she sees, mentally graphs it and say, okay, let's say this is the report for the month of June. When she looks at this, she realizes that her respiratory problems are 50. She saw 50 respiratory problems, menstrual cramps 46, general symptoms 43. And so it helps her to gauge exactly what she's seeing. And so looking at this, depending on what time of year it is, you may say, okay, respiratory problems is kind of anticipated. And then you look at 46 menstrual cramps. Why is it that we're seeing 46 females every month or in this particular month for menstrual cramps? That's a large number. So it kind of shifts the nurse to thinking maybe education is needed here in terms of how do you manage menstrual cramping, what's best, and medication. Teach them how to count their days, when to expect their periods, and what they should do in order to alleviate the pain and them, coming to the nurse just for menstrual cramps. So this serves as a great teaching tool, education tool for the nurse. And so some health education topics that you may find in the school system for our primary schools definitely are safe and unsafe touches, personal hygiene, nutrition, bullying seems to be a really big one, saying no to drugs, and definitely puberty and body changes. So those are the topics that we focus on in primary school, but that's not an exhaustive list. We rely on our guidance counselors to say, what else are you seeing? What are the students talking to you about? And then we use that as a guide to formulate a teaching plan. Our junior and senior schools, personal hygiene, nutrition and exercise, of course, abstinence from sex, teenage pregnancy, violence, behavior management, illicit drug use, good choices, bad choices. And then definitely we talk about career goals and choices. Here you'd see where our nurses engage in, like I said, education. We love to teach. And you see nurse bowls, they're teaching about safe and unsafe touches. We even have our own lifestyle dolls that we use to demonstrate. Each nurse should have one of these, they design it however they want. In the primary schools, really, this is used. And then she teaches about safe and unsafe touches, especially how we're coming off of the summer break. We realize that our molestation cases, rape cases, sexual activity cases, and involved cases they're increased after summer. So our nurses are definitely prepared for that. Occasionally, we have a training done by the SCAN unit on how to detect a sexually abused child or a physically abused child, any abuse in a child, so that you'll be able to pinpoint what's happening or that something is not right, even with one visit to the nurse. We have some students, and we call them our frequent flyers because, they always come around just to say, hi, what you doing? You have any water? That sort of stuff. And so we know they're seeking our attention. So we pay particular attention to those students that we see all the time, but they're not saying much. And so that's a great tool we use to figure out what's happening with this child. Why they want to see me so often? There's absolutely nothing wrong. And so we talked about referral agencies like SCAN. Some of our referral agencies, because the nurse cannot do it on her own. And even though we may feel that we're good counselors, there are specific groups that are geared towards counseling and detecting problems that we can't see. One of those agencies would be the Suspected Child Abuse and Neglect Unit, we refer to as SCAN. Adolescent Health Center, you had a presentation from Ms. Ranger a while ago. Accident and Emergency Department, Community Counseling and Assessment Center, we refer to as CCAC. Our dietitians that we refer to, and various child health clinics. And of course, the Bahamas National Drug Council. So these are all of the agencies that we would liaise with, we would call if we feel a need to refer our students for various services. And teaching, again, education of our school nurses. You see, we did our BLS. And so we tend to keep it very current. Next trainings in 2023, next year, November. Some nurses have completed their ACLS, and there's another group that's going to attempt it in the next couple of weeks. Visual acuity screening and training for our school health nurses, because then now we need to, what we found really is that after students have been home so long using their tablets and doing online learning, visual acuity has deteriorated, and a lot of children are complaining of eye discomfort. And so we saw a need to definitely ensure that our school nurses know maybe not how to prescribe medication in that regard, but definitely know that something is wrong and where to refer. And this vaping awareness training that was done with Bahamas National Drug Council. This came about after one of our schools reported that they found 10 young girls in the sixth grade in the bathroom vaping. That was unusual for girls, 10 girls, grade six girls in the bathroom vaping. And so it was not just one school. We got several calls from different schools or reports from school nurses that students were vaping. And so we had to bring in the Bahamas National Drug Council to address that. And first, they needed to teach us on how to address it because, of course, they can't go to every school. So our school nurses in the primary schools did a seminar on how to address this issue. Then you'd see Dr. Luki Carter, very passionate about what she does. And so she was demonstrating the harmful effects of nicotine on the brain. And so one thing we do know is COVID is very real and COVID is still here with us. And it has definitely changed the way school nurses work. It has changed the way our country works. It has changed the way our world works. And so on the 15th of March, 2020, our first COVID-19 case here in the Bahamas was realized, and all schools closed immediately to face-to-face instruction. And they were closed for about a year. And so when school reopened, we realized that we had to do things differently. Social distancing was a must. And so you'd see Nurse Pratt here hosting a drive through PTA meeting. And that was so foreign to us because we used everybody sitting in one room like sardines, just talking but of course that couldn't happen anymore. So parents assembled in the parking lot. Nurse Pratt got a bullhorn or spoke as loud as she could. And then that is how we hosted the drive-through PTA meetings, of course, in collaboration with Ministry of Education. And then the long Zoom meetings came about, before the online online meetings were not as popular, and they became more and more popular. And so we found ourselves engaging in a lot of after-hour PTA meetings with faculty and staff that needed much guidance on the school campus as it related to COVID. Now, seeing that school had been closed for such a long time, our nurses were challenged to go back into the school environments and then pretty it up, make it look friendly and inviting for those students who've been home for so long and were kind of afraid to come back into the school environment because according to them, based on what they were feeding off of their parents, that COVID was out there and COVID was going to get them. And so we had to make the school environment inviting and let them know they were safe once they followed the rules. And of course, you see by the billboards, we showed them what it is that they needed to do to keep themselves safe, wearing a mask, washing their hands, social distancing. And so because COVID is out there, we will definitely still see COVID in the schools. But we did take note that in this chart you're seeing February to June 2022, with the blue signifying staff and the green signifying students, we realized that in May, the country experienced a surge, and this time our students had the leading numbers. In May of 2022, we saw 67 COVID incidences among our school students and 51 among our faculty and staff. Now, maybe that's because the faculty and staff were not obligated to report that they had COVID. They just took vacation or stayed home or whatever they did. But the number was 51, the students were 67, because of course, if you don't see the students, you want to know why, then you realize that they had COVID. And so I feel that our numbers for our students is correct. And I think our numbers for adults, not so much. So now we're going to discuss isolation protocol on the school campus. And of course, we believe in safety first. So this protocol was penned by the Ministry of Education under the advice of Ministry of Health. So all individuals accessing the campus must wear a face mask and must have their temperature checked before entering the school campus. And that means every single person had to have their temperature checked. And so if the first temperature check is greater than 100, that was the first indication that something is wrong. And this is for our students. If one of the faculty or staff came and their temperatures were elevated, we sent them away. They were sent away to seek further care. But for our students, they were placed in an isolation area, and a nurse would attend to them, of course, wearing her isolation gown, her N95, and her gloves. That student was double masked. And then the temperature is again rechecked in 2 minutes. The reason the temperature is rechecked in 2 minutes by the nurse, because the personnel at the front gate was most often a security officer. And just as a means of attaining the right temperature, the nurse would check it again, not with an infrared, but with a digital thermometer in 2 minutes. Now, if the second temperature check is normal and the student answers no to any of the questions asked in relation to COVID, like, do you have any shortness of breath, any dry cough, any loss in taste or smell, or sore throat, or fatigue, or do you know anyone with COVID-19? They know to that. Then, of course, it's rechecked again in 2 minutes. And if that is still normal, the student is sent back to the classroom, mainly because there was no reason to keep the student isolated any longer because they said no to all the COVID symptoms. And you, as the nurse, did not find a temperature or fever. But if that second and third thermometer readings are elevated, isolation is maintained. The school principal is notified, and of course, the parent is called to come and get the student. Now, if the student has a temperature on the second and third readings, but does not meet the EPI alert, then we know something is still definitely wrong. And so that's why the isolation is maintained. But we can't say it's COVID because the student is saying no to sore throat, cough, colds, so maybe it's an earache, maybe something else going on. So of course, the student has to be collected by the parent and taken for further medical attention. But what if the second and third are elevated and the student is saying, yes, my mother has COVID, we live in the same house, we sleep in the same bed, I have a sore throat, I have muscle aches. So then we know that this student definitely still has to be maintained in isolation. The principal is notified, parents are called to collect the child to take for further testing. School environment is notified, school health services is notified, as well as the surveillance unit. The child is tested and followed up by the school nurse. Disinfecting and cleaning. For our non-suspected COVID cases, regular cleaning is allowed. For those highly suspected COVID cases, of course, I'm saying highly suspected because COVID has to be proven by a positive result. And most often we don't get the result right away, but we know someone who has all of the signs and symptoms of COVID, probable COVID case was in this room. And so Ministry of Education and Department of Environmental Health will decide how they're going to disinfect and clean that area. And so let's talk about some of the challenges that we would have faced at school health. Of course, for compliance with COVID protocol, some persons did not feel they needed to wear a mask. Some persons felt fine, their friend was fine. And so, of course, they'd sit down without a mask and talk to their friend, or there was no social distancing going on because now these children have been locked away for so long and now they want to congregate and hug and talk and share lunch. So we found that full compliance with COVID protocol was really difficult. Also, lack of adequate working spaces for the nurses. Now, because of social distancing, a lot of the school classrooms that the nurse may have been using before COVID was now being used by students because they had to spread out. And so the nurse found herself on the outskirts trying to perch somewhere in many cases, because now all of that, what we thought would have been extra space, is no longer extra space. And then of course, an increase in violence on a school campus. It's kind of hard to say why the violence increased, but I I can only assume that, definitely with social ills and some repercussions from COVID and being locked down, and then an inability to resolve personal issues among our young persons had a lot to do with violence in the schools. And so at those schools that we noted that the violence was erupting outside of the norm, we brought in a lot of counselors like Bahamas National Drug Counselors, or we referred to CCAC, or even got some police officers involved to come in and do talks with our young men and with our young girls to find out what exactly was going on. So here you see a photo of a knife that was confiscated. Well, actually was found on a school campus. So a student came to the school nurse because she felt she could trust the school nurse. She said, I can tell you where a knife is. And so she's like, okay, show me. And so, that was retrieved and handed over to school officials. And God forbid that somebody would have used that as a weapon later on in the day. And so I spoke about, lack of space as one of the challenges and not wearing masks during special functions and outings as being one of the challenges. Here you see an isolation area that was outside an isolation tent. Some schools opted for an isolation tent because there were no available rooms. And that posed a challenge because putting up the tent and taking it down became very it was not sustainable in some incidences. But we got through it. Hopefully this upcoming school year would be a much better one as it relates to that. The reward is few and far between, but school nurses love what they do. And so many times, schools just find an avenue or way to say thank you to their school health nurse, which is definitely a plus. It helps you to want to push a little harder. And so what are some of the plans for school health services as we go forward? You may have noticed that we had so many schools, 42 in fact, and just 27 school health nurses. We seek a one-on-one ratio, resident nurse to school. We came very close one time and then COVID came. And then so because nursing is definitely experiencing a shortage worldwide, we don't have that staffing resource to allow one nurse per school. So some of our nurses have 2 and 3 schools, and it's very difficult to build a rapport if you're not at that school every single day. But fingers crossed that maybe things will get better. They can send us some nurses. I don't know from where, but we'll see how it goes, But I feel that you should be in an environment consistently so that you can measure what's going on and stay in contact with your students, faculty, and staff so that they can, build a good rapport. And of course, secondly, improve the working relationship between Ministry of Health and Wellness and Ministry of Education by having routine conversations just to evaluate the effectiveness of what we've been doing. We may feel that what we're doing is top notch and we're killing it and we're doing a great job, but then not until we sit down and have that conversation, we realize that some things, we can do better on not just health side, but definitely on education side. The conversations have gotten better, and so we look forward to working even more closely with the Ministry of Education in hopes to making another school year even better. And so thirdly, a certification in school health nursing is what we would love to see happen, just to create a standard of nursing care and healthcare services provided to students straight across the Commonwealth of the Bahamas. School health nursing is different from school nurse. We have a lot of school health nurses. We have a lot of school nurses, but not school health nurses because it comes with a certification. That's something we want to concentrate on in the years to come so that we can have one standard of care and certification for our nurses. If you have any questions, I'll be happy to take them at this time.
Ms. Enfield, I thought it was an excellent, comprehensive presentation. I just have a couple points I want you to just expand on. One is Family Island School Nursing. What happens in those cases? And I think there are 1 or 2 rural schools in Nassau. what happens with the children there as it relates to school health services?
Okay, so school health services is kind of a, need I say, special service. Is offered on the islands of New Providence, not in the Family Island in the same forum. Students are seen regularly at their clinics on the Family Island, whereas nurses are sent, assigned to different schools to focus on school health. I don't know if that's clear.
Yes, you're correct. In New Providence, there are one or two rural schools such as Adelaide School, Gambia School, where the school, which is mostly primary, is right, either they're located within the confines of the clinic. I think Foxhill Clinic have that same situation.
Right.
So
Foxhill Clinic, we have Sandlands Primary and Foxhill Clinic kind of share the same ground. But we
right,
do have a nurse stationed at Sandlands Primary because Foxhill Clinic doesn't go for the full amount of hours per day. And the school felt that they needed a nurse there. And so we had one available at that time. And so now they have a nurse available to them. Gambia and Adelaide at some point earlier last year had a nurse available to them as well. Unfortunately, we had to pull nurses from those schools, and it was okay to do so, I feel, because Adelaide and Gambia have clinics close in proximity to the schools. So we felt that if something happened, the schools were close enough to the clinic to render some assistance.
yes, yes. And like she said, the Family Islands, there's an agreement with the Ministry of Education that your sick children would be seen at the clinic in their area, but the nurses at the clinic, someone is assigned to school health services. It depends on how busy the area is, but there is a surveillance of the school health population, especially like immunization, finding out whether or not they really did have their school medicals before school starts, and your at-risk students. Okay, I know when I worked on Family Island, those were a lot of the objectives that we had to deal with as a community clinic in a rural area.
Yes, ma'am. Thank you for that. Are there any other questions? Nothing burning? Anything I was unclear about? I'll be happy to explain.
Phil mentioned the availability of dental clinic for school health, school-age children.
So as it stands now, many of our students, primary school students with dental issues are seen at a dental clinic that is held at Stephen Dillard Primary School. Outside of that, our students are referred to the clinics for dental care, especially our older children. But there is a referral to a dental clinic for our primary school students at this time. We're looking to change some stuff, improve some stuff, but as it stands, it's just that one dental clinic that we send our referrals to for primary school students at this time.
Yes, the dental clinic at Stephen Dillard is more of a preventive type of clinic, to try and improve the dental health of many children. So it's a good thing. And of course, the children of higher ages would be assessed during their physical, the requirement to enter school. So referrals to the the dentist at their local community clinic. But preventive care is not done at the government clinics. It's only curative. So if you have a toothache, it's you know, if it needs to be removed. So that's a gap in our system for preventive dental health for school health children. I stand to be corrected, Nurse Henfield. Are there any current changes?
No, ma'am, you're correct. That's correct.
Ms. Hanfield, excellent presentation. Well, very well put together and beautifully illustrated. I was, a bit distracted in the last 10 minutes with something being sorted out for tomorrow for the students. But
Thank you, Dr. Moxie.
I wasn't sure.
Are there any other questions?
No, I was asked if you had mentioned anything about the eye services during your talk.
No, I did not, but there lies another gap in the system at this time. There was an eye program and COVID came and knocked a lot of our services off. And so that is something we're looking to restart again. But of course, our students that have eye difficulties and discomforts and conditions are referred to other clinics for further evaluation and care.
Okay. Because I know there's the one on Soldier Road next to Lowe's Pharmacy. That's the main Princess Margaret Hospital.
Yes, that's there.
A way we could close the gap by training more optometrists. But I think we need both.
Most
but
definitely.
For the screening, can they only be handled by an optometrist quite competently. So same thing in the persons with diabetes, when I used to, run those clinics, it was, these long waiting periods for the persons with diabetes to get their eye examined. Their eyes, examined, the annual. Well, it's supposed to be no less than an annual. More, frequent visits, but at least the waiting period was months, and that's been a problem for a long, long time, and it's still we can't seem to get that solved. The manpower shortage in ophthalmology.
Right, and we tend to keep a very close eye on our diabetic students, especially for the very same reason. So we try to see them more frequently than we'd see, any of our other students that seem stable. So we definitely keep a track on our diabetic students. Are there any other questions? Anything you'd want to know about at all, students?
At the moment, that was pretty straightforward again and very informative.
Thank you. But let me ask a question. Was it alarming to hear about the vaping in the primary schools? Was it just me that was taken aback when it happened, or is this something that's happening out there and everybody's aware it's happening? Because I was baffled when I heard
The vaping?
about primary schools. Primary school girls said that in the 6th grade.
Oh no, that's something that's been happening. That's a popular trend that's been happening for a while, so I wasn't surprised. Yeah,
It's popular among the adult population, I agree, but among our students in the primary schools and girls at that, I was really thrown with that. And it was, in our primary school, some trends
sorry.
What?
Sorry?
Go on, Jordan.
No, I was saying, well, the children are gonna watch what the adults do. I mean, they're very readily available. You could get them in the stores or any, from everywhere. So, I mean, it's not hard to get them. Mhm.
Yeah, so it's now becoming cool.
Yes.
It's looks very elegant, I guess.
Yeah, and you can get any
Smoke
flavor you
coming out
like.
and it make them look sophisticated, and so
Yeah.
I guess they identify with all of that stuff. But the other thing too is the packaging. I was on a website just this weekend and it's incredible. I mean, I must say they have somebody designing the packages of these things, man, and they have all kind of fancy names, for the different flavors and this beauty. I might have to admire the packaging. It's like colorful and artistic. And you ever saw the packaging? Some of these things coming.
Yes, especially our marijuana gummies.
Yeah, it's like
Those edibles
bright,
are
and
pretty.
children now start to associate that with candy, and these people, they need to be stopped because they know just how to attract the child, to the or even teenagers. Really, I think it's targeted more at teenagers. It's really not for children, but that's not. They're not really marketing to children, but they marketing to teens and young adults. You could tell from just the packaging. It's something that would appeal to them. It's cool and it looks hip and current and what's happening type of thing. So they know how to market a product. I could tell you that. Starting from the packaging, they sit there and they plan it.
Yes, that's awakening for
design
us,
the attack.
Dr. Moxie.
Pardon me?
I say that's very awakening. It's an
Yeah,
awakening.
yeah.
And it calls for a shift in the way how we educate and who we educate, because ideally, drugs, our target population would be either junior high, seniors, or adults. But now, paradigm shift.
And the other thing too now that I heard on a talk show just yesterday or the day before was the gang violence, that they're now saying that you can't wait till the child is 15, 16, because by that time they're already actually in the gang and hardened criminals. That came out of someone's mouth. So they're now saying you have to start from the primary school to break up this tendency to join gangs and teach them and put them into something positive. Because I reflected on that. I said that every child, it's now time for national service. And every child should be in some uniformed organization with discipline. You have to put it in them. The person was saying you can't leave it all to the school, the church, and these groups, and that parents need to step up. But I think along with the parents, you need some disciplined organization. I was in Boy Scouts and all of that. And, I still remember the lessons. Be prepared was our motto. And they send you out to camp and you roughed it and, all of those things. It all helps. Sunday school, of course, I was in that. And all of the things to do with church. So all of that was part of the upbringing in those days, where you were made to join things, So I don't know what happened to us, I can't imagine a child going through school and not being in something, some disciplined organization. Apart from the school discipline, the home discipline, and church. I think that's the other part of the raising of a child, the morals and the reinforcement, by church teaching. And there's nothing wrong with us sending our children to church, because in the Muslim countries, you go It ain't no choice. Am I going to church or to mosque, on Friday? You are going. You see the difference?
Yes.
And they have schools where they train these boys. They focus on males, of course. And the Quran, they have to memorize it. And you see them, they're doing that all day. I don't know when they learn science and history or whatever, else they want to teach, but they focus a lot on that Quran as, in their culture. So I don't, you don't want to become overbearing and so the child hates the organization, but I think we need national service and every child should be in something. That's how I look at it too. And from primary school, as the person was saying, you cannot wait until they're 15 and stuff like that to start to try to get them under control or, some will be just naturally good students and children. And then you have the at risk, that's the group, you attend to the ones who are already doing well and doing, what they should be doing. And then the at risk, you have to focus on them even more, because that's the ones can go either way. Either, they can be, what's the word, rehabbed or they may end up going the criminal side. So
You're so right. But Nurse Hanfield, that case of yours, one of your nurses, and in fact, you just exposed all of these doctors to a phenomenon that's in the Bahamas, but maybe it's not a phenomenon in the world or globally. But it's a good topic for research. And policymakers, they look at numbers. So, and for that type of incident you mentioned with primary school students, even one child vaping it's a phenomenon. So definitely it needs attention. So, I would, this is new to me. I wasn't aware of that. So yeah, this calls for action. I never knew that.
So Bahamas
Oh.
National Drug Council, what they did is, because it happened around, well, what happens in the school sparked, the campaign by Bahamas National Drug Council. And so if you find, and you'd see that in some corner stores, they have some stickers about vaping and, prettying up the packages. But they did do a small campaign, and I can only imagine it's going to get a whole lot bigger because it was something new, yes, among the adult population, teenage population, but our babies, I was just really, because I have a 13-year-old daughter, my baby is 13. And so I asked if she knew what vaping was, and I was like, she's not going to know what that is. And I asked her, just like, yes, mommy. And I was like, oh. So and it says that as parents we need to be more in tune in what is happening. Sometimes I know growing up as a child, parents would say this grown people stuff, and so that meant to you this does not involve you. But no longer are we just to say it's grown people stuff. We need to protect our children from it because they emulate what they see, just like Dr. Phillips say, it's there. They're seeing it, and of course they're going to indulge in it. So you saying this is just for grown folks don't mean they can't partake. They will partake if it's there, if it's attractive enough. So it was an eye opener to me as it relates to my own children as well. And I think we need to bring an awareness to parents to know that this is what our children are focusing on, not just you in the nightclubs, but children are doing it at school when you have no clue. Because this particular incident, what happened was the young lady stole the vaping stuff from her granddad and she brought it to school, and so they were trying it out.
Oh, wow.
So she bought that from home. He had
Wow.
lost it and couldn't find it. And so she was bringing it to school day after day after day and having a really good time. And he had no clue. Mom and dad and granddaddy had no clue what was going on. He just figured it was lost. So it says that we need to pay more attention to what's happening with our children. And then, as you said, Dr. Moxie, not just put it on the school system, but as parents, we need to focus more on our children, how what we do in front of them, because it translates into this is what I'm doing. Eventually, you're going to do this too, kind of thing. If mommy and daddy could do it, then I could do it as well. So, how then do you do something and tell them not to do it? One time ago, yeah, now, not so much,
Yeah, that's true. Yeah. Yeah, that brings me to smoking itself. Now, cigarette smoking, that's still around too. And unfortunately, we have companies who produce cigarettes right here in the Bahamas. I still don't know how they got permission to do it with us in health, allowing that. I guess, well, it was beyond our control. But if we are serious about this health in all policies, that should not have been allowed to happen, because the cost, would come down. That makes it more attractive to young people. The cheaper the product is. And so the Palm company, they even have ads up showing healthy young people using, smoking, and under the palm tree thing, they bring it, because they know that's a symbol of relaxation and, enjoyment and all that kind of thing, the idea of the coconut palm. So they even name their product for something that's healthy. But so, we need to do more again to lobby against these companies. And the advertising, there's advertising. I don't know if you ever noticed, right across from AF Adley on the bench, that hundreds of school children have to use, if they're going south. Every day they are imprinted with that. The Palm, I don't know if it's still there, but I made a note of that. The Palm Cigarette Company has an ad on that bench at the bus stop, or had an ad. I don't know if it's been changed, but all of that is imprinting. Every day you see that, and eventually it may get, to the students. There is a lot of work to do with smoking and tobacco control, that, that field. I don't think we do enough over here. Yep. So any comments, students? Or hello, can you hear me?
Yes, we can hear you, Dr. Moxie.
Oh, okay. Good. So, any final comments, Nurse Enfield or students, or Nurse Turnquist?
I had a quick question. I know earlier in the session we discussed the issue of adolescent pregnancy and, ensuring students are well educated when it comes to sexual activities. I'm curious, in terms of the school health educational system, has sex education been a part of that education, or is that still pretty much taboo in our system?
Well, I'll tell you from our experience, there was an incident where two young girls in grade 6 were caught kissing in the bathroom. And so my school nurse was very distraught about it. And she wanted to read them the riot act and do all that stuff. But I said to her, some things you can touch and some things you can't. You don't know the background that those students come from, what they see at home. And then you have to be very careful of putting your personal belief out there on other persons, right? Now, I may or may not believe in same-sex relationships, but I told her our focus should have been not on same-sex relationships, but definitely not at grade 6, the age. So there is still some taboo there, some lines, some blurred lines. So we try to be very careful in how we address it. But that is not just a job for the school health nurse. We get parents involved, guidance counselors involved, and send students for some counseling. so that everybody is involved and can make the right decision. Because it's real touchy, it's still, I guess, taboo, like you say. But we have come across a whole lot of that. And so we tend to not just ignore it because we don't know how to address it. But we do know that at this particular time, you should not be engaging in sexual activity in any form, same sex, opposite sex, mainly because I think your education is more important. And we tend to push that more than anything else. And then we refer for counseling, parents and students, and those relevant authorities and agencies take it from there. I hope I answered your question.
I'd like to add to that, Nurse Henfield, the Ministry of Education, they have a routine sex education program in their curriculum. It's called Family Life. And the Ministry of Health, the school health services, there is in primary school now. Now, maybe we may have to start it earlier than grade 5 or 6. There's a template that health education publishes. I don't know if any of you students have seen it. It's called Growing Up Boys and Growing Up Girls. And this is a kind of a standardized health education for, well, sex education. And just educating the child on changes, puberty, likely not really getting into sex, but puberty and changes in your body. So an awareness of changes. And that is a routine for the Ministry of Health.
Yes, we tend to use that as a guide for our school nurses. So we still use that.
Thank you. That's what I really was curious about, the Family Life program, whether or not that was something that was still in place. But I'm curious, in terms of, based on both of your experience so far, do you feel that the educational program, this Family Life that the Ministry of Education currently has in place, is effective compared to some of the things you're seeing in the clinical environment, some of the teenage pregnancies, the STIs, STDs? Are students still aware of these issues and still making the mistakes, or is it that they're making poor choices because of a lack of education?
That's a loaded question. Personally, you can teach 10 persons in a classroom. This is just my view. You can teach 10 persons in the classroom, give them everything they need to know, and there is still 2 or 3 that choose the wrong road, make the wrong decision. So I think the information is out there. I think maybe the method of getting it to them is outdated. Possibly. Maybe that same information needs to be repackaged to be more attractive or gets their attention, whether it's music or art and drama, something like that. Because I think that whole view of being in the classroom and just sitting down and teaching them and showing the VHS and all that stuff is outdated. And I don't think it gets the attention of the students, especially when everything else out there is just so much more attractive. So maybe it's just the way we deliver the message. It's sticking with some, and I think for others, it's not quite sticking. It's not getting their attention. They have to make the mistake. Like my grandma say, you have to buck your toe before you can catch sense and that kind of stuff. Some persons have to make, even with adults. And we hope, hopefully, we prefer not to be that way. But you're never going to get 100% of the persons doing 100% of what they should be doing all the time. That's just my view on that.
I agree with Nurse Henfield. Along the lines of everyone, even students in this class, each person have a different learning style, okay? So some people may be visual, some may be audio, they learn better by listening, by watching stuff. I agree, yes, we may need to be more aware of learning styles of different students. But there are other factors at play here, especially in today's world with the internet. You have internet influence round and round. So you may have to look at the socio-economic, the home environment of some of these students, and pick out the at-risk people, okay, who may need further. Maybe you may need to do a home visit. Ms. Hanfield, I think you mentioned that home visiting is a part of what the school nurse does, especially if you suspect that there's some social issue going on. And these are the students, if you follow them, these are the ones who either end up getting pregnant later in life or having health problems, social problems later in life. So education takes on many factors, including the socioeconomic environment, your home environment, your parents, what you're exposed to, what type friends you're with. So it's a lot of things that could be improved. And I'm not going to say the system is tight, cannot be tweaked. Yes, it can be tweaked, and keeping in mind all of those factors.
Thank you.
I guess we could soon wrap, but some years ago, it was more in the height of HIV/AIDS. The group came from Jamaica, a young group they put together to do it as a musical. I think they call it the Ash Group or something like that. And they did a whole music on all the musical on all the STDs. And like all the school children went to see it. Like it was organized and put on several times so that I guess the older children went. I don't know if they went down into the primary school level, but that was successful. It's probably somewhere on Facebook or still now, and obviously that's a lot of work, but I guess these days you have to use YouTube and those kinds of things to get your message out.
Yes, you're right. Facebook, YouTube. Yeah, we're gonna have to be more modern in the way that keeping in mind learning styles, different learning styles of people.
Right. Yeah. Yep. So any further questions, students? Mr. Finley is here. Yes. Okay.
Yes, good afternoon,
So,
Dr. Moxie.
Hello, welcome. Thanks for joining us and giving your talk. So let us thank Ms. Hanfield for a very good, excellent presentation.
Yes.
So, okay, we appreciate the time it took to put that together. It was very, very good. So anything else, students, or Mr. Request?
No, I thought you did a very good job. Excellent job.
Thank you so
Thank
much.
you.
The pleasure was mine.
You're welcome.
Okay, all the best. Take care. Thank you. Okay, so your final introduction for the day, Nurse Turnquist.
Okay. I would like to introduce our only male nurse. Okay, Mr. Chesmond Finley. He's a registered nurse who holds a Bachelor of Science degree in nursing from the University of the Bahamas. He's currently deployed at the Ministry of Health and Wellness in the Maternal and Child Health Unit. And male health is one of his passions. So you're gonna find that it'll be a vibrant, very informative session. I turn you over now to Mr. Finley.
All right, good afternoon, everyone. So I'm Nurse Finley, and we're gonna do a brief overview of the Male Health Initiative. Okay. So again, I'm Nurse Finley, and we'll do an overview of the Male Health Initiative. So we'll go over the vision and mission and the Male Health Initiative, why was it needed, the goals, and our scope of work. So the vision, all men are made to be aware of their role in the health of the family and have access to a comprehensive male-oriented healthcare service. And our mission, to provide men with a comprehensive and holistic health and wellness service through education, collaboration, and advocacy to empower and inspire all men to live longer and healthier lives. So the Male Health Initiative is attached to the Maternal and Child Health Unit of the Ministry of Health and Wellness. And the Male Health Initiative was birthed from the International Conference on Population and Development in Cairo in 1994. And what this conference spoke to was advocating for men to be more involved in the involvement in their family. So the conference called for men to be active in the upbringing of their children, active in family planning, active and responsible in sexual health and sexual wellness. So one practical way of doing this was to encourage men that when their spouses or their partner go to the clinic for family planning or antenatal care, that the men should go with them and not just perhaps sit in the car, but go into the clinic, go into the room with the doctor and the nurse to see what the process is all about and to have your input and be informed. So this is what the conference was calling for. But over time, research was showing that men were not living as long as women, men were not coming to the doctor, and men were generally sick. So the program had to evolve from just focusing on population control and into a more comprehensive and holistic male-oriented service. So what was the research showing? So the research that you're going to see now is basically the same back then. So the World Health was finding that women were living longer than men. Harvard was finding that men fell ill at younger ages and have more chronic illnesses when compared to women. The same study from Harvard also found that men were more likely to have bladder cancer, kidney stones, and to live riskier lives when compared to women. And then the Cleveland Clinic in 2019 with the Mention It survey. This is perhaps one of the most quoted surveys when it comes to men's health. It found that 2/3 of men tend to wait as long as possible to see a doctor if they have any health injury or any health symptoms. The survey also found that 41% of men were told as children that men don't complain about health issues. So this one particular statistic here speaks to the psyche that this was being embedded in men from childhood, that, hey, if something is wrong with you, you don't complain, you just suck it up, toughen up, you're a man. And then perhaps one of the most famous quotes or statistics, 72% of men would rather do household chores, such as cleaning a toilet, rather than seeing a doctor for a health concern. So when we look at the leading causes of death in the Bahamas in 2014, we see that ischemic heart disease is the #1 cause, followed by hypertensive heart disease, cerebrovascular disease, assault, diabetes, and HIV. So the number of deaths for both sexes, when you look at that column, you would say that number is relatively small or low. But however, when you look at the column that speaks to men specifically, you would see that over 50% of all ischemic heart disease deaths are men. When we look at cerebrovascular disease, nearly 50%, assault and violence, over 90%, diabetes, 50%, HIV and AIDS, over 90%. So what does this chart also show us? This chart also shows us that all of the leading causes of death in the Bahamas in 2014 are all
Excuse me,
preventable.
Mr. Finley.
Yes,
Just a
sir.
correction with HIV/AIDS. You want to do your proportions again for that? It's closer to 50 something percent. The
Sorry,
total was 99 and males were 56.
sorry, I misspoke. So
Yeah,
over 50%.
yeah.
So when you look at the leading causes of death listed in this chart, all of them are preventable. Now, you may question number 4, assault and violence, and that's fine. But what we tend to find is that the majority of persons who succumb to violence, crime, they actually are perpetrating crime also. So when we listen to the Commissioner of Police in one of his most recent press statements, he said that 50% of the persons who were killed in the past 2 or 3 weeks were actually being monitored by the police because they were out on bail because they were accused of committing a violent crime. So this is something that's very important for us to pay attention to. So in the United States, they had a Men's Health Week, and Congressman Bill Richardson in his address said that recognizing and preventing men's health problems is not just a man's issue, but because of its impact on wives and mothers, daughters, sisters, it becomes a family issue. And when we look at the rising cost of healthcare, it just doesn't make it a family issue, but it makes it a national issue. And in 2011, the annual cost of dialysis in the Bahamas was more than $14 million. So the government of the Bahamas in 2011 was allocating 14 million for dialysis treatment. In 2018, it nearly doubled to $25 million annually. So these are some of the common conditions that affect men. And one of the conditions I want us to look at just briefly for a moment is prostate cancer. So before the pandemic, the American Cancer Society research found that 1 in 7 Black men will be diagnosed with prostate cancer. In 2022, the research now says 1 in 6 Black men will develop prostate cancer in their lifetime. The Bahamas Cancer Society is now saying that 80% of Bahamian men who have been diagnosed with prostate cancer have advanced disease. So this is really important in understanding men's health, understanding why it's so important. So in the Ministry of Health and the Male Health Initiative, one of the things we focus on is the health and wellness of men and boys. One of the reasons why we look at boys or we focus on boys is that we have the belief that healthy boys will likely be healthy men. We believe that if we can teach boys now how to eat healthy, how to develop healthy habits and practices, that as they grow and develop into men, that those habits will continue with them. We also look at the reproductive rights of men, as this is one of the founding pillars of the Male Health Initiative. And one of the things we often advocate for is that men continue to go to the clinic with their partners for family planning, for antenatal visits. We would always want the father to be in the room during the antenatal visit for the father to hear the fetal heartbeat of his child. You go to a private physician and you can go into the physician's room and hear the fetal heartbeat. But a lot of times in our public setting, because there is a lack of spacing, and sometimes the fathers are not able to come because of work obligations or because they think this is a woman's responsibility, they don't go. But we've been pushing and advocating for men to be more involved, to go into the clinics and be a part of this process. It's something really special when you can hear the heartbeat of your unborn child. We also do work in terms of violence prevention, this work is strictly policy. It's strictly policy. One example is about a year ago, we did some work in terms of gender-based violence. And we also was looking at the legislature to help change the law regarding the age of consent for girls. The age of consent for boys is 18, but the age of consent for girls is 16. So when you hear legislation speaking to the age of consent, Male Health Initiative had a voice in that. So some of the goals of the Male Health Initiative: we provide a free and comprehensive male-oriented health service. And to help you understand what that means is basically we cater to the men. So we try as much as possible to provide a service that's convenient to encourage men to come to the clinic. It's going to be a challenge getting men to come to the clinics in general. So as much as possible, we try to cater whatever our service is to fit your needs. If you believe that you can only spend 30 minutes in the clinic, we do our best to get you in and out in 30 minutes. If you say you can only come on your lunch break, we'll do our best to accommodate you. We do work in terms of violence prevention among men and young boys. This work, again, is a policy-based, and we also encourage for planned families where both parents can provide for their children. We also promote abstinence as the first choice and encourage as much as possible the delay of sexual activities. I know some people think this is very old school, very outdated, but this is one of our founding pillars also to promote abstinence. We also educate boys and men about their sexual and social responsibilities. So one of the things I actually tell boys, once I tell you, you shouldn't be engaging in sexual activities, you should focus on your studies, and you insist, I let them know that the minute you engage in sexual activities, you must be prepared to be a father also. Because what we find, what Male Health has found, was that some of our boys were not even using condoms. What some of our boys were using in schools were plastic bags and baggies. We know now that we have a ban on plastic bags that we used to get from the grocery stores. So we don't know if our boys are necessarily using condoms, but this is a challenge that we have. And we see it perpetuating as some men grow up, they have children that they're not necessarily fathering out in the society. And we also want to use mass media to raise awareness about men's health. Men's health is very important, and a lot of time it goes under the radar. So we use mass media to raise the awareness about men's health. And we actually did one study so far related to men's health in the Bahamas. This was before I came, but it was a very good study. So as it relates to the activities of the Male Health Clinic, I will also speak to you about the plans going forward, because as a result of COVID-19, health resources had to be reallocated and the program was shuttered to an extent. And it's our hope that we can have everything up and running in November. So we had a weekly male health clinic. So the Male Health Clinic was based out of the 4 polyclinics. That's Elizabeth, South Beach, Flamingo, and Fleming Street. And basically how the clinic worked, it was an appointment-based system. So all you had to do to be a part of our clinic was be 18 years or older and have an appointment. Once you met those 2 criteria, you were allowed into the clinic. You didn't need to be previously diagnosed with a medical condition or anything like that. Just be a male and 18 years and older and have an appointment. So basically how the clinic system works is you have an appointment. Once you come into the clinic, you will be registered. You'll go through all of your health screenings, stuff like that. And then after that, we'll take you in to see the doctor. Our doctors are typically family medicine specialists. and family medicine residents. You do blood works routinely. All of your lab works are absolutely free. So this is a free health service. So anything that the clinic does for you is completely free. With the consent of the client, of course, we do the STI screening and the HIV testing, and everything remains confidential. So going forward, it's not just about getting the men back in the clinic. Before COVID, we averaged about 120 men between our 4 polyclinics. But going forward, it's not just about getting men back in the clinic, but it's also about closing the COVID-induced screening gap. So the Cancer Society of America estimated that a little over 9 million screening tests that normally would have been done in the US in 2020 did not occur as a result of the COVID-19 pandemic. We don't have numbers to say what it is here, but we know too that our screening would have decreased. So we know once we restart, we need to increase screening with our men. Whether it's colonoscopies, PSAs, we need to get the screenings ramped up and increased. So the screenings are going to be very, very important to us. In terms of attracting men into our clinic, we know that we have to be very targeted and systematic in what we do. So we can put flyers out on social media, we can do PSAs and stuff like that, and all of that is fine and good, and it will yield good results. But we also need to look at going to places where men frequent. So some places that men frequent: barbershops, bars, hardware supply stores, building supply stores, gyms, farmers markets, stuff like that. So we can reach as many people as we possibly can. So that's basically how the clinic system works. In terms of the annual men's symposium in partnership with UB, this was an awesome, is an awesome symposium. We have speakers that speak on a wide range of topics. It's not just related to health, but it's related to everything that concerns a man. So it's fatherhood and parenting, it's finances, it's sexual health, it's relationships, it's will and estate planning. It's a wide array of topics. So you can have a doctor, you can have a lawyer, you can have an accountant. At the symposiums, we have persons doing free vision testing, free rapid HIV testing, and a whole host of other things is going on. Going forward, we recognize that we have some key areas that we need to focus on. We need to focus on responsible fatherhood. Sometimes when you listen to the commentary in the media and you look to see what's happening in society, you can see that absentee fathers is having a negative impact on us. It affects our kids' performance in national examinations. It affects them in terms of how they are socialized, how they are brought up. It affects their grades in schools. So we know we have to focus in on fatherhood. We also recognize that we need to focus on finances. One of the things that COVID-19 has taught us is that it's not just good to have $100 in the bank saved, but you need to have so much saved that you can survive 6 months, if there is another shutdown or another lockdown or another pandemic. So we know we need to speak more about finances. We also need to speak more about how do we manage relationships? How do we manage the stress of relationships? So there are a lot of things that we're looking to focus in on moving forward with the men's symposium, and we're hoping that to do this in person and not virtual. We would love to do this in person. The Department of Corrections workshop. This is really important as we help to prepare men for life outside of the prison. Typically what was done is we would go in and we would speak about health and health related topics. And very rarely would we assist with job placement, because sometimes what you would find is that some of the men in prison, they're skilled carpenters, they're skilled electricians, skilled plumbers. So very rarely did we help in the past with job placement, but going forward, this is something that we want to look at in a very monitored approach, As it relates to our primary and high schools, we're going to start off with the primary schools first. I know you would have remembered Sister Hanfield talking about speaking to the kids about puberty and hygiene. So when it comes to male puberty and hygiene, Sister Hanfield and school health services would always reach out to male health. And we would go into the school, the grade 4 and 5 boys, and we would speak to them about puberty and hygiene. I'm going to tell you some of the alarming things that we find. When you're talking to them about cleaning the penis, the uncircumcised boys, a lot of them do not know that they should retract the foreskin and clean under the foreskin, clean behind the head of the penis. A lot of them do not know that. Additionally, we try to do certain things just to break the ice, and we'll ask these kids, what's your favorite soap? What's your favorite toothpaste? And sometimes what we're finding now is some kids don't have a favorite soap, they don't have a favorite toothpaste. And then when you look at their presentation, you can tell that they're coming from a home environment that's not up to par. So that's some of the alarming things that we're seeing with our primary school students. Fortunately, some of our guidance counselors are really good and our school health nurses are really good. So what you would find is that the school would provide assistance. And social services is always there to step in also. As it relates to the high school, what we have done is we've talked about sex, STIs, and vaping. Now, vaping is new to me too. I actually had to read up on it. I had to watch YouTube videos on it. But these are very common things in our high schools. And I can tell you from a personal encounter I had when I was deployed at the HIV center, and I was asked to go to Doris Johnson and to give a talk on STIs to the 11th and 12th grade boys. And as we went through the presentation, the boys started telling me that they have to skin one in order to win one, meaning that they were not on my run in terms of not even using condoms, but being abstinent. So they were not going to abstain, and also they were not going to use protection. So sometimes getting this message of abstinence on safe sex practices across to our high school boys can be very, very challenging. Another thing that we're looking to speak to going forward with our public school boys is an essay competition, and not just the primary but high school also. But we would like to do an essay competition regarding the infiltration of gang violence into the schools and how it affects academic learning. We'd also like to do possibly another essay competition regarding the effects of not having sufficient positive role models. When you walk the corridors of our public school systems, what you would realize is that the majority of the staff are female, they're women. And for kids that are coming from homes with no fathers or no male figures, that's going to be challenging for them. And what we would like to do too, because our presence is mainly in the public schools, we would like now to start infiltrating the private school system, because everything negative that's coming from a school will always be the public school first. Some private schools are very good at masking and covering up what is going on, but we know that, hey, we need to be involved in the private schools as well to assist and to help get the message to our young people. In the past, we've always had a great relationship with our religious and civic organizations. Um, Even through the height of COVID-19, when COVID-19 was at its worst, the churches were still calling, trying to get male health to come in and do health talks and do health screenings and so forth, but we couldn't do it because of the restrictions at the time. So we have a really good relationship with our religious and civic organizations. And it's this relationship that we have that actually works out very well in helping us with our health education literacy program. So when we often do health presentations to churches and to civic organizations, it's just a simple phone call. You tell us a date and a time, and once we're available, we come to you. And that's usually how it works. The community walkabouts are usually done around the clinic. But like I said, we want to be a little more targeted with this going forward. And we want to now also target the places where men frequent, the bars, the gyms, and stuff like that, places like that. We know that the radio shows and mass media works, but going forward, we want to enhance it. So we know PSAs are very, very excellent. So we can do audio PSAs that can play on popular radio shows like 100 Jams, Joy 101.9, and Guardian Radio. But we can also do video PSAs that can play on Cable 12, that can play on ZNS, Facebook, and YouTube to raise awareness about men's health. So picture this for a moment. You're not a medical student, you're just an electrician or airplane pilot, and you're driving in your car and you hear this. Did you know 1 in 6 men will be diagnosed with prostate cancer in their lifetime? Call the Ministry of Health Male Health Clinic for your free health screening. Don't delay, call now. Hearing something like that will say, hey, that could be me. I need to check myself out. So we would like to do more in terms of reaching out to our public. And in addition to reaching out too, we have oftentimes ignored our migrant population. All of our PSAs, all of our videos from a male health perspective is in English. So we know now, we recognize now too, that we need to convert it to Creole. We need to convert it to Spanish also. So these are some of the things that we've done, and then this is the way we're looking forward also. So this was a previous flyer that we used when we initially had a public awareness campaign. This flyer got us in a lot of trouble because we had a lot of patients calling. I think this flyer was launched at the ending of January 2020. And by February, the middle of February, the male health clinic was booked out for the entire year. Just these 2 flyers alone. So this is one of the things we used to promote the male health initiative. We used to walk around the inner city, Beantown, and other communities, and we would just place these flyers on lamp poles. Persons who own convenience stores will allow us to put them up. And when the public saw that there was a male-oriented health service, like this really caught their attention and made them interested. A lot of people only know about a female-oriented health service. So when we talk about a male-oriented health service, they think this is something that's kind of brand new, even though it's not, but it draws their attention and it makes them really interested. So we send this out and we said, these are the things that we do. With the prostate screening, we had to be very deliberate and letting them know that the first screening is always going to be a blood test unless something abnormal is detected, but it's always going to be a blood test. We give out condoms, anything that you can think of, we try and do, like I said, to accommodate our men. And if any of you work the male health clinic in the future, what you would find is that the men, after they would have seen the doctor, they sit back down and they wait for everyone else to finish, because it's not just about being seen by a doctor, but it's a family environment. It's the camaraderie. It's being able to share as men and talk and commune with each other. It's a fellowship. So a lot of the men look forward to coming to the male health clinic, and we actually had men coming from some of the family islands that actually had a male health clinic going on. So some of the men would leave their family island and come to Nassau for the male health clinic in Nassau. And I must also commend Dr. Gerard DeVoe, the family medicine specialist that saw our patients, because it's one thing to get a man to come to a clinic, but it's another thing to get him to keep coming. And the male health clinic has a high retention rate. We maintain and we keep our patients. Some clinics, a patient comes today and then they don't come anymore. That's not us. If you miss your appointment, we're going to call you the next day to see what happened, to see how we can reschedule you, stuff like that. And in terms of being accommodating to our men also, if you were to tell us you live in the South Beach area, but you work in the East and you would prefer to be seen at Elizabeth Estates, we accommodate you. We know sometimes that our polyclinic system won't allow for that, but under the male health system, we will accommodate you, because at the end of the day, your health is what matters most to us. And we want you to stay in care, stay connected to a physician and a team of healthcare providers. And this would have been our clinic schedule. So every week we were at a different clinic. The biggest clinic for us was Fleming Street. Fleming Street was our busiest. Our least busiest clinic was Elizabeth Estates, and that's only because we had one doctor. But at the other three polyclinics we had 3 doctors. So we were seeing up to 15, sometimes 20 patients. But at Elizabeth Estates, because we only had one doctor, we were seeing about 10 to 12. And these are our references. Any questions? Any questions?
I'd like to start off, it's not a question, it's piggybacking on what you said. First of all, it was very comprehensive presentation. I enjoyed listening to you. And I'd like to add, from a policy standpoint for Male Health Initiative, you mentioned a lot about human rights, and that's a buzzword in today's communication. So,
very much.
The World Health Organization in 1946, they declared that understanding health as a human right was very important. Okay, so that created a legal obligation of countries to ensure access of all people to accessible, affordable healthcare. Okay, so here comes universal healthcare in 2015, increasing the access to healthcare to all, including men, and this is how men's health has morphed. Okay, universal healthcare in the Bahamas under NHI have have opened the doors to free healthcare, free access to private physicians. Okay, and we need to get the word out that once you're registered for NHI, you can register under any physician, and a lot of these physicians are specialists, the same specialists that are in the public sector. Most of them are employed have their own businesses in the private sector. Okay, so NHI has pushed the agenda of universal health care that is accessible, it's affordable, basically it's free for you as the patient, okay? So men and boys can go to a physician, you can get preventative health care, you can get curative health care, all free, okay? And right around the corner from you, wherever you choose, whatever clinic you choose that's in your area. So I just thought that I would bring that to you.
Right, and that's so true, Sister Turnquest, because one of the things that we do, and we don't like to say it, but we actually refer patients to NHI. Because of COVID-19, it allowed us to make a little more connections and network a little more. So we met a few persons from NHI. So persons who needed to see the doctor, we actually referred them to NHI and they were able to sign up and select a doctor of their choosing. Additionally, we don't just refer to NHI, but we actually refer to some private physicians who can simply tell us, hey, Mr. John Doe came, he's in care, because we wouldn't want to refer a patient out and then they fall out of care. We can refer out as long as we can know that that patient remains in care. So it's not about the Male Health Initiative hoarding patients. Our big thing is just knowing that you're in care and you're being taken care of. Any questions, Dr. Moxie?
Nurse Finley. Yeah, just looking back historically, we had Alphaeus Bullard and Mr. Ezekiel Munnings and myself who had worked on the Men's Health Initiative in the early years. And we started off by having, similar to what you were doing now, the symposium at Golden Gates Assembly, and for several years, and getting the word out. So that's many years ago.
And still trying to get the word out today.
Yeah. So I guess we tried to lay a foundation for you.
It's a pretty good foundation.
Yeah. Thank you. So I think I think what you said was most comprehensive. I'd asked Adolescent Health how your group, and I asked you this question last year, I guess it'll be my standard question. Out of 3, school health, adolescent health, and your group link up. And I remember last year you'd said, there's some overlap and this kind of thing. So any further progress on that, or basically you refer to each other as necessary then?
Yes, as necessary.
Okay.
School health will refer to me mostly in the months of September and October. September and October, and then sometime around February and March. Yeah. And sometimes it's coming from school health, and other times it's coming directly from the school's guidance counselors.
Oh, okay.
Well, Dr. Moxie, I've only been here a year, but from what I've seen from the school health nurses, they have requested Mr. Finley to do their growing up boys, because the boys tend to identify with a man, with a male.
Yeah, it has to be done by a male.
So I found that even though we're still in COVID, the educational side is continuing.
Okay, good. I'm going to ask something controversial. You spoke about condoms and the boys using, and you always have this conflict between, wanting boys to abstain until they're old enough and married and doing the right thing and all of that. But then they I don't know, just active, they want to experiment, their friends are doing it. And so what about, what's your position on condoms, in schools or condoms well, the HIV center does provide free condoms, but I
Mm.
guess it'll take a lot for a 15-year-old boy to march up to the HIV center. And although
Yeah.
I don't think, what's their policy? They really don't have a cutoff age. I don't think they're gonna say, oh, you're too young to take some condoms, because you'd only be taking them if you're active and you need them. So
The
and I guess,
to the best of my recollection, I think you needed to be 18.
oh,
Yes.
I mean, for boys to
Yeah.
even get, okay, because from the
But
surveys, I didn't hear you mention the youth risk survey, which
right.
clearly showed that boys they start sexual activity before, in general, before girls. I think,
Mhm.
what is it, 15 or
Right.
14, and the girls are 16 or something like that. And these are thousands of school children, I think, were surveyed.
Yes.
And so it definitely reflects the true picture, the reality.
And this issue
So,
was brought up also by the former Minister of Health, Dr. Sands. And he said that this has to be harshed out with the government policymakers and the stakeholders like the Christian Council and stuff like that before any changes to any policy can be made.
mhm.
So we
I
know
know
that
it's,
the
yeah.
pushback will be from the Christian Council saying 18 because abstinence. But
Right.
it's a difficult issue.
The 16 for girls and 18 for boys, which is another anomaly that came up when we just discussed adolescent health, like what is the policy? Is not,
Right.
synchronous. You want them to wait till as late as possible, because we all know that's better than children really starting to experiment and
And
losing
children
focus
having
on
children.
studies and all of that. Yeah, and condoms burst and they don't put them on in time, and they want to try it out a little bit, and
Yeah.
without the condom, and this kind of thing. So, but at least I guess that's one method, that the male has some control over. I guess that's the point I'm making, because it's male health we're talking about,
Right.
But sometimes, they may find it hard to access it. It's embarrassing to go into a pharmacy. You're 15. Everybody's looking at you. You asking for condom, what you need condom for, and you're only 15. What is,
And the majority of your pharmacy workers are going to be women too.
right. No,
So,
you get it right from the front. Like you go to QVS, they're displayed at the front. And right there's, it must be so difficult if you if you really trying to prevent your girl from getting pregnant, and you're going ahead having sex, you've experimented, you're continuing. Hormones are raging, but you're listening to the lessons learned from, the establishment, school, guidance counselor, church, everybody's saying, don't get your girlfriend pregnant. And, they're not the message won't be use condoms. It's just abstinence. And
right.
I don't think the studies are bearing that out, that, saying abstinence good. Some will do that, some young boys are Christian and they decide, okay, I'm not doing it until I'm married. Fine. But then you have some who may decide today, then tempted tomorrow, then,
Dr. Moxie,
That's-
condoms are also available at the government clinics, all government clinics.
Okay.
But
Are they free?
They are free, right?
Okay.
The patients, the young boys, they become very creative. They may send the young women in for them.
Okay.
So you don't know, they
Okay.
may send an older boy or somebody who
That's
is
true.
18 or above.
Right.
So the access to it, if you really want it, all government clinics.
Yeah.
provide.
I think what we need is a study on teenage fathers. This came up too. That's why this day is such a useful day, because you sort of think about all of the problems on the same day. And they sort of seem to reverberate and go back and forth between the different programs.
Yes.
So the
Be-
teenage father phenomenon came up, and we were saying, boy, you don't even hear about that group.
No,
I
you're
don't
right.
think we've done a study on them.
No.
Why not? I mean, that's a group in the population.
Yes,
What's
it's
going on in
something.
their heads? How do they adjust to being a teenage father? That must be like the most daunting task. I could think of you barely a man. I mean, you're barely an adult, and all of a sudden you have a child to take care of, and you don't have a clue. So I don't know what focus you'll put on teenage fathers, not just the general population. Is there anything for that group apart from the parent craft? I guess they just have to join the training like that. So, anything for that?
Yes, not particularly. It's an interesting area. Yes.
Yeah.
That requires more research. So
Yeah.
that's a gap.
Yeah. What are their psychosocial needs? Because they must be, I guess they feel powerless, in a way, because nobody want to trust them with the baby. They made the baby, but they're not good enough to be the father. They're not mature enough. That's a better word to use. Because they are so young.
Yes. That's why the parent craft is supposed to, like you said, rightfully said, right, bridge that gap.
Mhm.
Yeah, but you
But
have
is it attractive to a
no.
16-year-old boy? I mean, would he come into the clinic and sit with 30-year-olds?
Yeah, it's a stigma. It's a
I'm
stigma.
being
You're
devil's
right.
advocate, just saying what happens with that group.
It's reality.
Yeah, the girls
There
get a
needs to
lot of
be a
attention.
focus. Yeah,
The
there need to be
chase.
more focus on men
Yeah.
and boys.
Yeah, because the
I
girls
agree.
get paid, so they are taken care of, and of course they should be. But the fathers are sort of hanging out there. If you're a teenage father, yeah.
Well, maybe society does that. But a teenage father, they don't drop out of school. Well, not for being pregnant or anything, but that, like you said, the psychosocial side of it is very important. So that's a huge gap we need to fill.
Definitely.
Yes, I take your point, Dr. Moxie.
Yes. Okay. I don't even know if we have one study on that group now that I think about it. That's, territory that could be, new knowledge can be generated, which is what research is all about, new knowledge.
Yes, I agree. And you have what, 13 students in front of you?
That's true. They could have done their study on that if I was thinking. They did their studies on diabetes, which is good too. They focus on that too. But I'm sure one of them probably will take it up as their doctor of medicine,
Yes.
in the future, if it hasn't been done before, take a section of it to do or something,
Agreed.
interested in pediatrics or
male health.
Male health, yes.
Urology or family medicine.
Yeah. In fact, one of my students has done extremely well, Dr. Sean Knowles. I could bring that up. I mentioned it way back. He has a clinic called Emmanuel.
Yes, with Dr. Morgan.
Right. And that's a wonderful private clinic.
Oh.
And I will tell the students that Dr. Sean Knowles won the Dr. Mortimer Moxie Prize for Best Student in Community Health when he was a student, and he was outstanding. I mean,
he is actually one of the physicians we refer patients to.
Okay, wonderful. Yeah, he's a balanced doctor, the social, the psychiatric.
Yes.
And then the medical. He's
well-rounded.
Well-rounded, right, yeah. And Dr. Morgan is also another excellent physician. Unfortunately, I think he's on vacation because he does a really good down-to-earth talk with the students. So You know something, maybe we could still get him to do it, although he's on vacation. Let me make a note. Because that's you know, what they call a real talk, you know. Some of the other talks a little more up in the air, but he sort of brings it down to reality. His students see it as an HIV talk, you know, about really what's going on in the community. Something like what Mr. Finley is teaching. But his focus will be HIV, you know. That he may still be able to do it. But he would have been a speaker in the lineup tomorrow, you know, in the HIV lineup, I should say, but he's on vacation. So, but I could still ask him and see if he's able to do it. If not tomorrow, because there isn't time, maybe another day, or maybe Wednesday, you know. Yeah. After the clinic and after lunch, maybe he could do his talk. Yeah. So students, any other questions? Still some issues, you know, that are not, we can't solve, you know, here. You know? But I see nursing officer Turnquest has been talking about policy quite a bit. And so that, you know, that's where it all starts, you know, you develop the policy and then you implement it and you do the monitoring and evaluation for the impact of the policy and redesign. So that's, you'll learn about that in health education. They do program planning, a bit of that in their talk. But you notice how many times nursing officer Turnquest has spoken about policy. Students, you wonder any reaction to that? Which health policy is a whole area of study in itself, you know, so but I just thought I would highlight that because I think of all the speakers so far, you're the one who's spoken about policy the most, Nurse Turnquest. You know, from the time we started the clerkship, you're the only, I think it's the administrative position you hold. You're now thinking a lot about policy and policy doesn't always have to be top down. It could be bottom up too, okay? And it could be clinic policy or administrative or ministerial policy. So all policies don't have to come from top to, you know, to the bottom or to the lower ranks of the service.
Right.
Okay.
And at the clinical level, as physicians, you would need to know in particular, like the Sexual Offences Act. You need to, you could just Google it. Just familiarize yourself with it. So when patients present themselves to you, you will be able to recognize, hey, this is trouble. Okay, so you know, that's a good thing that you should be familiarize yourself with.
Mm-hmm.
Also, general policies and procedures of the institution you're going to work for, because you might be employed, or years ago you were employed by someone else, and you're now with a new institution. They have their own rules and regulations. So it may be not a point for studying something, but just reading it and being familiarizing yourself with the rules and regulations of that institution. And I'm sure, Dr. Moxie, they have a timing for that, when to introduce that to you.
Yeah, during health systems, they'll get
right
some of that. Yes.
So it's a time for everything in your training.
Yeah, this is a good orientation for them, you know, because medicine is one thing, but then, you know, learning the system is another thing that you're going to work in. So all of this is very, very good for them. Yeah. Even when you go into private practice, you still interact with the, the Ministry of Health system at some point. If you're in NHI, if you're in whatever, if you want to report something to surveillance, it's still a partnership and a collaboration between the groups. Yeah. So any further questions, students? You all have been taking it all in, but you're free to roam about the country or about the clerkship. Okay. So what are your thoughts? You've had a whole day, so somebody or a couple of you all, please give some feedback now. So we can hear how, the teaching was received. We like to get some feedback.
Good afternoon. If I may, I think that the overall session was really informative. I didn't know the wide, scope of maternal and child health. So it's quite refreshing to hear everything from school health and men's health, some of the initiatives, some of the modern research. So I really thank you all for taking the time to make this full day available to us. I was writing so much notes and definitely would look to see how I can be involved in the future. So I do thank you all for offering this to us today.
Great. Anyone else? That was Mr. Vernon Davis, who
Thank
is our
you.
future, probably gonna be a future CMO. He's on the right track. So any other reflections or reaction? We're not too late at all. We really made up the time.
Yes, could you guys hear me?
Yes.
Yes, overall, I also thought all of the sessions were extremely, extremely informative as well. And I think I even have more respect for nurses, to be honest. And I especially remember when Nurse Hanfield mentioned how even though like the school nurses, they'll work throughout the school year, but even when school closes, they'll still be sent to like other areas as well. That was something that I didn't really was aware of. So just knowing that, it just gave me even more respect for them. But overall, it was a really great session from this morning to now. It was a lot of information to take in, but it was so valuable, and I've definitely learned a lot today.
An important area, this whole maternal and child health and men's health. Yep. Basically covered the whole population, if you were to really look at it in one sweeping day.
Yes, and Nurse Hanfield was calling from Harbor Island. She's working in Harbor Island.
Awesome. You'd never know. She was so she was so relaxed and oh man, she did such an excellent job.
Yes, it was.
Everybody, Mr. Finley, so please give them a general, warm hug from all of us over here at UWI. All your people, tell them they were awesome.
I will, and I was impressed.
If I could have sent a virtual fruit basket, I would have.
Oh. I was impressed with the attendance of your students right to the end, from the beginning to the end.
Yep.
I that was impressive for us.
Right. We're monitoring
so, congratulations, right?